Hello, everyone. This is Howard Catton, Chief Executive Officer at the International Council of Nurses, and absolutely delighted to be able to join the CREMS Nursing Congress. I know that the CREMS University Congress is not only a really important event for Austria, but also across the German-speaking nursing world, and you're having contributions from European international colleagues as well. We're just a few days before International Nurses Day 2024, so let me also bring you early greetings for International Nurses Day, and I'll be saying a little bit more about that as well. I'm going to give you an overview of the current state of the global nursing workforce based on work that ICN has done or has actively participated in with organizations like the World Health Organization, the World Economic Forum, with OECD as well. But before I do that, for those of you who don't know, the International Council of Nurses is the body recognized by WHO and the UN institutions to speak on behalf of the global nursing profession. Our membership, our national nursing associations, there are more than 130 currently in membership of ICN, and the global nursing population is around about 28 to 29 million. You can see our membership there on the map. We were established in 1899. This is our 125th year anniversary, and we were the first health professional association to be formally recognized by the World Health Organization shortly after the Second World War. We work extremely closely with them, and you can see our president here, Dr. Pamela Cipriano, just towards the end of the pandemic. This was with Dr. Tedros at one of our regular meetings at WHO. One of the most significant pieces of work that we've undertaken with WHO in recent years was the first ever State of the World's Nursing report. You can see on the slide an image of the front cover, and I hope also this world map you may have seen before, which showed us the distribution of nurses right the way around the world, how those 28 million nurses, where they're working. It's based on number of nurses per 10,000 population, more nurses in the bluer countries, fewer nurses in the red countries. And you can see here very clearly that we have a maldistribution issue. Nurses of the world are not spread evenly across countries or regions, and that difference between some African countries and some high-income countries can be as much as 10-fold. Whilst this is a map showing the distribution of nurses, if I were to put up a map to show the level of health needs, it would look very similar, with the biggest health needs, the greatest burden of health being in those countries that you can see here that are in red or in the pinker colors. So we not only have a maldistribution of nurses, but numbers of nurses does not match where health needs are. In fact, is virtually a converse picture. This table is from the State of the World's Nursing Report. It just reinforces and shows you the hard numbers in terms of that maldistribution issue. Density of nurses in Africa are 8.7 per 10,000 population. The average in Europe up at nearly 80, and some European countries where it's even more than that. And again, you can see that countries or continents like Africa and the Eastern Mediterranean region have less than 1% of the world's nursing population. So we have a distribution issue, but we also have a production issue. This table that you can see is from latest OECD report, but it's based on 2021 figures. It shows you the number of nursing graduates that are being produced across OECD countries. The average, the red in the middle there, about 42.8, 43 nurses per 100,000 population, but a massive range from, less than 10 in Bulgaria, Colombia, Luxembourg at 12, through to over 100, 115 for Australia and for Switzerland as well. You could probably see Austria there below the OECD average, around the 28, 29 mark. And this table, this is back to the State of the World's Nursing report, but you can see here again the differences in graduate numbers, the production of nurses against the WHO regions. Again, very low production, lowest production numbers for Africa and the Eastern Mediterranean. But interestingly, look at Europe at 31.9, 32. Some way behind the production numbers that you see for the Americas at more than 80. So a distribution problem not aligned to health needs, and also a production issue. What does all of that then mean in terms of global nursing shortage? Let's start again with State of the World's Nursing, top left-hand corner there. That report told us for the first time that we had a global nursing shortage of around about 6 million. In addition, we know, based on the same data that we collected at that time, nearly 5 million nurses who are due to retire over the next 5 to 10 years. So, that gives us over 10 million nurses that we're going to be needing, that we're either short of or combined with the numbers that we will need to replace. All of this data, though, was pulled together before the pandemic. And we all know the terrible toll that the pandemic took on the physical and the mental health of the global nursing workforce. ICN reported extensively. We produced many reports, 2 particular here: Recover to Rebuild, Sustain and Retain, you can see in the bottom right-hand corner. The impact we described as the COVID effect on the global nursing workforce. We did some modelling to say that we could see another 2 to 3 million nurses leaving earlier than they otherwise would have done as a result of the pandemic, pushing that replacement number up to more like 12 or 13 million. But then we conclude in the bottom left-hand corner with a study by the Institute of Health Metrics and Evaluation, University of Washington, who came out with a report saying that actually the world is 43 million health workers short, 30 million of which would be nurses. That was the scale of the shortage. Now, that seems a huge jump that we've gone from 6 million 2020 to 30 million. But it's worth just considering how University of Washington arrived at that figure of 30 million. And that's because they used a more ambitious indicator of universal health coverage. Universal health coverage is a key indicator that WHO use to determine the needs that we have for health workers or shortages. University of Washington used that indicator, but as opposed to setting it around 50%, said, no, if we add more ambition in there, if we want to do more on primary healthcare, on prevention, on education, on mental health, for example, what would be the impact of that on healthcare workers? And as a result, they came up with this bigger number. So when we say how many nurses are we short around the world, how many nurses do we want, how many need? Actually, alongside that question, you have to say, what's our ambition for global health? What level of health needs do we want to meet? Because if we set our ambitions at a more modest pace, then the shortage figure is going to be less. It's going to be considerably more if you take a more ambitious view on the future of global health. This slide, this is the sort of, I know it seems very wordy, but this is the sort of slide that I always used to like is when I was a student, because it's my attempt in one slide to paint a picture to give you some of the key facts of the current state of the world's health, not the nursing workforce, but the current state of health. Half the people of the world don't have access to fundamental healthcare. 100 million people plus in extreme poverty due to medical expenses. 41 million deaths, 70+% of the global total accounted for by NCDs. We saw a reduction in vaccination rates amongst children. That's climbing back up again now. The very ever-present and increasing persistence of humanitarian crisis due to war and conflict. 274 million people expected to need humanitarian aid. An aging population, and more than 10% of the world's population living with mental health. 50% of us predicted to have a mental health issue at some point in time. If this is the state of the world's health, when I look at this, what do I see in terms of how we're going to address this? I see nursing work from primary healthcare, from chronic disease to infection to the humanitarian response to mental health. None of this is going to be achieved or dealt with without our nursing workforce. We regularly hear that we're called the backbone of the healthcare of our healthcare systems, which indeed we absolutely are, because we are ever present in terms of addressing health needs. Let's go back to the nursing workforce. So what does that, given that picture I've painted, you might be thinking of it's one of shortage, of a growing demand and supply gap, which it is. But if I show you this slide, again, back to OECD, about how many nurses we have now across the OECD compared to 2011, so it's 2011 to 2021, the most recent data. The white dots are where we were in 2011, the green dots where we are in 2021. You can see pretty consistently countries have more nurses now than they had 10 years ago. OECD average is at 9.2 on this. But for politicians or policymakers who want to say, we have educated more nurses, we have more nurses now than we did 2, 5, 10 years ago, the evidence absolutely is there to support that. The nursing workforce in these OECD countries has grown over the last 10 years. Whether it's grown sufficiently to meet health needs is another question, but in absolute terms, the numbers have grown. Has that growth come from the education of new nurses? That's not a conclusion that we can jump to. And this table shows you the share of foreign trained nurses across, again, selection of OECD countries. So the reliance on nurses who are educated somewhere else than where they are now working. OECD average of 8.7%. That's really significant. Nearly 10% of OECD countries on average, nearly 10% of their nursing workforce comes from other countries. They have not educated or homegrown nearly 10%, but it goes to a massive 46% in Ireland. Austria is up there at more than 10%. And we know that since the pandemic, because of high-income countries' failure to invest sufficiently in the education of their own nursing workforce, they have more actively, aggressively recruited from other countries. And it's international recruitment which is driving, in part, the increase in their nursing workforce, but not without some pain and some consequences. ICN has reported an awful lot on the impacts of international recruitment and trends and issues in the last couple of years. This is just one story that we worked with the BBC on about the impact of the outflow of nurses from Ghana to the UK. And we, at the time, said it felt to us as though the situation had now increased to a point that it was getting out of control. This was more than just the normal patterns of international movement that we've seen for many, many, many years. There'd been a significant spike, and we were increasingly hearing from nurses around the world about the negative impacts of that. In their own words, you can see quotes here included in the BBC story from nurses and medical staff as well about how care was affected. We're not able to take more patients. There are delays and it costs more and people die. We heard from nurses about services simply having to stop because they'd lost their nurses. Impact on immunisation rates was an example that was raised in this story. And also exposing a myth that ICN had been highlighting. It's not new graduates who are being necessarily targeted for recruitment. It's experienced nurses, critical care nurses, specialist nurses as well. So we end up, they said, this nurse said, we end up having nothing, no experienced staff to work with. Even if the government recruits, we have to go through the pain of training nurses again. So just a summary of some key points in relation to what ICN have been saying about international recruitment at this time. We shouldn't forget that this hasn't happened by accident. This is a result of choices, political policy choices about how many nurses to educate, deliberately not educating enough some countries to meet their own needs, on the assumption and on the reality that they will then go and recruit from other countries. But the 7 or 8 high-income countries at the forefront of the recruitment activity we are seeing are frequently recruiting from countries with much smaller nursing workforce, a lower ratio of nurses per head of population, making it even more difficult for those countries to meet their own healthcare needs and arguably widening global health inequalities. There is a global code of practice, WHO. We support that, but we think that the weaknesses in it have really been exposed over recent months. One of the elements of that global code is that if there is recruitment from countries that are in a weaker position, there should be evidence of mutuality, of give back, of compensation. And we simply are seeing very, very, very little evidence of that. If you start to think about the costs of educating a nurse, let's say even from a low middle income country, it may cost 20,000. It's going to be more than that in the high income countries, 50, 60,000. And then if you think that the nurse has some specialist education as well, you know, the education, the cost that's been invested in each nurse's education runs into tens of thousands, even possibly hundreds of thousands of euros or dollars. But when we have seen an agreement where there's any money being paid back, one with the UK, for example, it was £1,000 per nurse. So the agreements that we have are not delivering real mutuality of benefit. Those agreements still allow high-income countries to recruit some of the weakest countries around the world. We've said that we think there should be a moratorium of active recruitment from those most vulnerable countries. There's an assumption, excuse me, that the Philippines and India will continue to be major suppliers of nurses. Those countries have their own health needs demands, and Philippines has a shortage that it announced last year as well. So there may be risks associated with relying on that. We still continue to see individual cases of poor, even exploitative practices of individuals, the global code not working. And something that ICN said just recently, following a meeting I was at with nearly 25 of our national nursing associations in Africa, who said to me, this all feels, Howard, like a modern form of colonialism. Our valuable resources are being taken. We're not being compensated for them adequately. It widens the health needs that we have, and it impairs and undermines our ability to get onto a more sustainable course. There is undoubtedly significant work still to do in relation to the global architecture around international recruitment. But at the same time, and here is a huge conundrum and contradiction that we have. At the same time as we have a global shortage, we have unemployed nurses. Again, many of the examples to this is on the continent of Africa. We don't have good data, but from conversations I've had in some countries, it can be between 10 and 20% of nurses who our association leaders believe are unemployed. Reason for this is that their governments are restricting employment, are putting caps and thresholds on hospitals and employers. So even though they've educated those nurses, the jobs aren't there for them. This isn't an issue that we should only target our advocacy at high-income countries. Low, middle-income countries are simply not investing sufficiently in their own nursing workforce and creating jobs and decent work for them as well. Why does all of this matter, colleagues? You know this, but in summary, global health needs are increasing. We've been thrown off track to meet universal health coverage, sustainable development goals as a result of the pandemic. The risk of future pandemics is present. And importantly, and an issue we're trying to shine more light and attention on, and as the pandemic illustrated, when health fails, economies fail. And therefore, for health economies to recover, to grow, for us to see a global road to economic prosperity and growth, it's not going to happen without investment in health. And when that doesn't happen, we see increased risks to safety, to quality, to harm to patients, and yes, including death. People would expect ICM perhaps to highlight some of those more negative consequences, but this is a table, again, from an OECD report that's tucked away, but I thought was very important to pull out, and I share it quite widely, because it shows, based on OECD work, perception of nurses and physicians of the safety of their workplaces, whether they think they have adequate staffing levels and whether the pace of work enables them to ensure the safe delivery of care. About only 50% of nurses across these countries reporting to OECD thought that their workplace was safe. That's a huge flashing red light indicator, warning of risk to patient safety. Interestingly, what you also see in this is that managers' perception of safety is often higher than that of nurses or of physicians. So not just from nursing groups, but from people like the OECD, the safety indicators indeed are flashing. Safe nurse staffing is an issue that we could talk about for another half an hour, and I'm not going to, but it comes up as a priority time and time again in our conversations with national nursing associations. We have produced a number of policy statements on the evidence base for safe staffing. We've done work with WHO collaborating centres and safety centres on the issue, and we firmly embed staffing into the global patient safety agenda. I was able to present to health ministers in Chile recently at the Global Patient Safety Summit, specifically on nurse staffing levels and safety. And it's important that our advocacy very clearly makes the case for safe staffing being two sides of the same coin. It of course is fundamental to patient safety, but it's also fundamental to nurses' safety, nurses' well-being, and their retention and well-being. And I said a few moments ago that it all matters because of the risk of death. And this is a graph from last year's or 2020's WHO Europe region report on health workforce, a ticking time bomb, they referred to it as. So this is what WHO Europe acknowledge and show that life expectancy increases clearly where you have more doctors, nurses, and midwives. This is based on the three professions, but of course, as we know, overwhelmingly, nurses are the largest largest share. So the evidence is there, not just from nursing academics like Linda Aitken about the risk of death. It's here from WHO sources as well. For all of these reasons, colleagues, we'd lobbied very hard, WHO, that we needed a second State of the World's Nursing report. Dr. Tedros announced that at our Congress last year. We've started work on it. We'll be looking to produce that second State of the World's Nursing report at the end of this year. And that report will then drive the next global nursing strategy. This is the current global nursing strategy, 2021 to 2025. The next global strategy will be developed based on the recommendations, the findings from State of the World's Nursing. Your health ministries will already be starting to collate data on the nursing workforce to submit to WHO as part of the process for developing the State of the World's Nursing report. I encourage you all, through your organisations, associations, to find out who the focal points in your health ministries are for submitting the data, and for having with them about what the data is that they are submitting, so that you're sure and confident that the data accurately from your country that's submitted accurately reflects the reality of what's happening in your country. But it's not enough to just do this work within the health space. This issue of investment is a huge global political issue. We've all heard over recent weeks the big debate about how much countries are spending on defence, for example. We need that debate around health at the same high level. ICN has been working to take the messages about investment in nursing and health to G7 and G20 groups through interventions and attending meetings. At our Congress last year, we were privileged to have the Premier of Canada, Justin Trudeau, address the conference and then meet afterwards with the ICM board to talk about global health issues. We talked about climate change and universal health coverage, but we talked a lot about investment in health care and healthcare workers as well. And that's the sort of table that we need to be at. What has ICN done? What are we doing in terms of our advocacy, our policy work? I've mentioned a number of documents and reports already, all freely available on our website. This is our Charter for Change that we produced last year for International Nurses Day 2023. Our 10-point plan of what needs to be done to value, protect, respect, and invest in our nurses. This is to you, to me, to the nursing profession. This is motherhood and apple pie. These are obvious, straightforward policy issues that need to be put into place, but they're not happening consistently around the world. And from recruitment to retention to leadership to advanced and specialist practice, they're in these 10 points, and our associations are using this very actively in their advocacy, in their working country. It aligns absolutely with the strategic plan as well. So there is no excuse from politicians or policymakers to say, we hear that there's a problem, what do we do about it? We don't know what to do. We are clearly providing the solutions as well. Which brings me to this year's International Nurses Day, the theme of which is the economic power of care. In just a few days from now, we will be releasing a new report containing economic evidence about the importance of investing in nursing and care, not just produced by ICN, but produced by economists, eminent economists from other organisations that we've worked with to bring forward the evidence for investing in nursing. But for too long, people have considered that caring is perhaps a free good, or have dismissed it as having no or very little economic value. That's wrong, and that needs to be turned on its head. And our focus this year on the economic power of care is intended to help and support with that. There are some positive signs. Organisations like the World Bank and the World Economic Forum, both organisations that we have been working with over the last couple of years, now have health investment much more clearly on their agendas. The World Economic Forum has a council focused on the care economy. But all of that work needs to translate into changes in the actual dollar, pound, euro investment in health care. And if what I say, what ICN says, if the evidence, if none of that is strong enough, then this is our global ambassador for nursing, Princess Muna Al Hussein from Jordan, who delivered this message at the ICN Congress. She talked about nurses as a force for global health. She talked about our work being the foundation, not just for health, but for peace, security, economic stability, sustainability. That the world, she said, simply cannot afford not to invest in you, in nurses and nursing. And now is the time to shift the nursing narrative from invisible to invaluable through the power of investment. We have a couple of big events coming up this year and next year, colleagues. You want to hear more about these issues, to come, to join, to share, to learn, to make new friends and networks amongst nursing colleagues, then the APN conference is in Aberdeen, 9th to 12th of September, and Congress, close to you, relatively, Helsinki, 9th to the 13th of June next year. Be great to see as many of you as there as possible. ICN continue through all of this time to very actively work with and support our nurses who are in conflict zones and humanitarian crisis. Our Nurses for Peace initiative, it's not something that I've focused on here today, but just to show, again, very active part of our work right now. More information available on our website about how nurses around the world are showing solidarity and support for their colleagues who are in some of the most challenging parts of the world right now. Thanks very much for the opportunity. It's been great to be with you only virtually, perhaps one day in person. And I wish you all a very successful rest of your Congress. Thank you.